Good afternoon. This is Jason Carter from the Otsuka Field Medical Affairs team here today to talk to you about opioid use for chronic pain, screening, monitoring, and interplay with mental health conditions. So we're going to start by talking about some CDC recommendation for prescribing opioids for chronic pain. And this would be outside of active cancer or palliative care, end-of-life care. So if we look at data, back in 2012, over 259 million prescriptions were written for opioids here in the United States. Actually, a 7% increase from 2007 to 2012. So when we look at opioid prescribing and opioids for chronic pain, there's really some recommendations that we need to look at as we prescribe these for our patients. One thing we need to consider is non-pharmacologic therapy and non-opioid pharmacologic therapy are really the preferred options for chronic pain. Clinicians should consider using opioid therapy only if the expected benefits for both pain and function are actually outweigh the risk to the patient. So, and if opioids are used, then they should be combined with these non-pharmacologic therapy and non-opioid pharmacologic therapy as appropriate. So before we actually start opioid therapy for chronic pain, we should really establish treatment goals with our patients. And these should be realistic goals for both pain and function, and should consider how therapy will be discontinued if the benefits don't outweigh the risks that the patients may have. Clinicians should continue opioid therapy only if there is a clinically meaningful improvement in the pain and in the function, and that those outweigh the risk to the patient's safety. So before starting and periodically during the opioid therapy, we should actually be discussing with our patient the known risk and realistic benefits of the opioid therapy and patient and clinician responsibilities for managing the therapy. So when we start opioid therapy for chronic pain, we should prescribe immediate release opioids instead of using the long-acting or extended release opioid. When the opioids are started, we should prescribe the lowest effective dose. We should use caution when prescribing opioids at any dose, and should then be carefully reassessing the evidence of the individual benefits and risk when we increase the dose, especially when we go above 50 milligrams of morphine milligram equivalents per day. Long-term opioid therapy often begins with the treatment of acute pain. And when these opioids are used for acute pain, we should really prescribe the lowest effective dose of the immediate release opioids. Should prescribe no more than the greater quantity than needed for the expected duration of pain, severe enough to require the opioids. Oftentimes, 3 days will be sufficient. Typically, for acute pain, more than 7 days is rarely needed. Clinicians should evaluate the benefits and harms with patients within the first week to 4 weeks of starting the opioid therapy for chronic pain, and when we increase the dose. And we should continue to evaluate the benefits and harm of continued therapy with patients at least every 3 months, if not more frequently than that. And once again, if those benefits don't outweigh the risk associated with continued opioid therapy, then we should optimize other therapies and work with patients to taper those opioids to lower doses or potentially discontinue opioids. Before starting and periodically during continuation of opioid therapy, we should evaluate the risk factors for opioid-related harms. We should incorporate into the management strategies to mitigate that risk, including offering other medications when the patient's at increased risk for overdose. Clinicians should review the patient's history of controlled substance prescriptions utilizing state prescription drug monitoring programs or PDMPs or drug monitoring programs to determine whether the patient is receiving opioid dosages or dangerous combination that put them at risk for overdose. The PDMPs are a valuable tool that we need to take advantage of. When prescribing opioids for chronic pain, we should utilize urine drug testing before starting opioid therapy, and also consider urine drug testing at least once a year to assess for the prescribed medications as well as other controlled prescription drugs and illicit drugs. We should also avoid prescribing opioid pain medications and benzodiazepines concomitantly whenever possible. The patient needs mental health treatment with benzodiazepines, at that point we might want to consider bringing in a mental health specialist because it does put the patient at risk for overdose. We should also offer or arrange evidence-based treatment, usually medication-assisted treatment or MAT for patients with opioid use disorder. According to the 2016 National Survey on Drug Use and Health, 11,807,000 individuals 12 years of age and over have misused opioids. Of those, only a small percentage, actually 2.6% or 307,000 people, used heroin alone. Now, when we look at the total of patients misusing opioid pain medications, that's closer to 11.5 million people. And of those 11.5 million people, the majority, or 10.9 million people, have misused pain relievers only, while a smaller percentage, a little over 5%, or 641,000, have actually misused pain relievers and heroin together. Now we look at some data around the rate of opioid prescriptions dispensed in the United States. If you look on the left side of the chart, this is actually the rate of prescription per 100 individuals in 2006. On the right side, the rate per 100 individuals in 2017. So what we actually saw is, after a steady increase in overall prescription opioid rates, the total number of prescriptions dispensed actually peaked in around 2012 with more than 250, actually close to 255 million prescriptions at an average rate of 81.3 prescriptions per 100 patients. Overall, the national opioid prescribing rate actually declined a little from 2012 to 2017. And in 2017, the prescribing rate actually fallen to the lowest that it had been in a little more than 10 years, at an average of 58.7 prescriptions per 100 patients. So at a total of 191 million prescriptions, so down a little over 60 million prescriptions. You can see here on the chart how, especially in the South, looking at, Kentucky, Tennessee, those that, in 2006 were actually above 107 prescriptions per 100 individuals, or more than one prescription for every individual in the United States. And by 2017, that had actually fallen to the next tier. And you can kind of see, as we see a shift in the colors, how we are starting to see a slight decline in the rates of prescription opioids through many of the interventions that we've done in the United States. Now we look at changes in opioid overdose death rates across the United States. And what we see is statistically significant changes in drug overdose deaths involving prescription opioids by select states from 2016 to 2017, whether we see an increase, decrease, or no change. Now, some of the states did not have established criteria. So when you look at gray, the states in gray, that information was not adequate to meet inclusion into the study. So as you see some of the darker colors, we see increase in prescription opioid deaths. The light pink, it's stable. There was no significant increase in deaths. And then for a couple of the states, we actually saw a decrease in deaths. For example, with Tennessee, Oklahoma, Maine, and Washington, we actually saw a decrease in opioid overdose deaths. So when we look at mental health and opioid use, it's interesting. We look at the data of the 115 million opioid prescriptions that were dispensed in the United States. Of those, an estimated 60 million, so over half, actually over 51, are received by adults with a mental disorder. And actually, if you look at the likelihood of receiving an opioid prescriptions, patients with mental health disorders are actually more than 3 times more likely to receive opioids. So actually 18% of the adults with mental health disorders receive prescriptions for opioids, compared to only 5% in patients without a mental health disorder. Also, when we look at patients with chronic pain that frequently suffer from depression that can exacerbate symptoms of pain, we should really consider strongly using medications such as tricyclic antidepressants or SNRIs, antidepressants, to help us maintain the symptoms of those patients, unless it's otherwise contraindicated. Moreover, patients with mood disorders are twice as likely to use opioids long-term for pain. Patients that have mood disorder are also at an increased risk for opioid misuse, as well as a higher risk for overdose. Also, use of psychotropic medications increases the likelihood of opioid misuse. And when we combine benzodiazepines, as I mentioned before, with opioids, it really puts the patients at risk for overdose. So patients requiring both a benzo and an opioid really need to be closely monitored, and as I mentioned before, consider coordination of care with a mental health specialist because the patient is at risk for overdose. So because psychological distress frequently interferes with the improvement of pain and function in patients with chronic pain, we really need to be utilizing validated instruments to assess for co-occurring mental illnesses such as depression and anxiety. And there's several tools out there that have been validated. You know, the patient health questionnaire. You've got the 2, the 4, and the 9 item PHQs. The Pharm.D or Hamilton Depression Rating Scale, probably not used clinically as much. The Zung Self-Rating Depression Scale or the Zung Assessment Scale, all tools that can be utilized for depression in patients that potentially have anxiety symptoms. The GAD-7 or Generalized Anxiety Disorder 7-item scale is a common scale that can be utilized to assess that. Also for other disorders such as PTSD, the PC-PTSD or primary care PTSD scale is a commonly utilized scale, as well as the CAGE questionnaire for drug use should also be considered in assessing patients for mental health issues. So we also want to look at risk assessment tools when you're utilizing opioids in patients with chronic pain-related issues. And there's one thing that we can do. It's a very simple thing where it's a single screening question where you simply ask the patient, how many times in the past year have you used an illegal drug or prescription medicine for non-medical reasons? I know we're all busy when we're seeing patients, but I feel like we certainly have time to at least ask a simple question to help better assess our patients. But there's also tools out there that we have, some validated risk assessment tools for clinicians that are treating pain. Now, some of the tools may have copyright, may have limited use, so just make sure before you utilize any of these tools that you've adhered to the guidelines for utilizing the tools before you make copies and use them. So if we kind of briefly go through some of the tools we have, and these tools have been validated in studies. However, they do all potentially have different limitations. You know, the opioid risk tool is a brief 10-item patient-completed written questionnaire, maybe one of the most widely used risk assessment tools in the field. Ask for information such as personal family history of substance abuse and psychiatric issues. And the tool actually classifies patients into risk categories, either being low, medium, or high risk. As I mentioned before, there's some limitations, some potential inconsistencies in ratings and some imprecision in ratings. The brief risk interview is also a commonly utilized tool. It's short, anywhere from about 5 to 10 minutes. It's actually a clinical interview validated risk assessment tool. Questions that are asked are topics such as past misuse of opioid medications, the patient's presence of mental health disorders, personal history of substance abuse, family history of substance abuse. Also incorporates information from past medical records as well as prescription drug monitoring programs or controlled substance databases. It also classifies patients into risk categories a little different from the opioid risk tool or the ORT. It actually does low, medium, high, and very high. So, and that can actually be downloaded for free. And once again, it has limitations and imprecision as well. We also have the SOAPP and SOAPP-R. So the SOAPP, the Screener and Opioid Assessment for Patients with Pain, it's a 24-item completed written risk assessment questionnaire, uses a 5-point rating scale, asks about such topics as impulsivity, cigarette smoking, overtaking medication, past history of substance abuse. It classifies patients into a low and high risk. So there's actually no medium category, so you just qualify as low or high. Now, the SOAPP-R is a 24-item patient-completed questionnaire. It's actually a revision of the SOAPP. It's a widely used risk assessment tool, and it's a 5-point rating scale in asking patients about such topics as impulsivity, legal problems, past substance abuse, and past sexual abuse. And it actually classified patients in risk categories, kind of like the SOAPP, in low and high risk. While it does refer to a medium category, there's really no validation on the use of the medium category. We also have the drug abuse screening test. It is a 26-item self-report, yes or no. It can give up to 1 point with scores of 12 or more, indicating substance abuse problems. And we also have the audit, the Alcohol Use Disorders Identification Test, or the audit. It is a 10-item screening tool that looks at drinking behaviors, alcohol-related problems, and assesses consumption in the audit. Well, we hope that you enjoyed today's presentation, and as a reminder, you can find many other resources on PsyQ.org, as well as keeping up to speed and on the go by following us on Twitter and LinkedIn, or subscribe to our YouTube or podcast channel.